Thank you very much indeed, Stephen, for that very kind introduction. It's a great pleasure to come and speak here on home turf, as it were. And thank you very much for taking time out of your evenings prior to Christmas to come and listen to this talk, which I hope you'll find, first of all, of interest, perhaps entertaining, and even perhaps valuable. The topic is focused on Parkinson's disease, and I thought I would begin just by giving a little perspective on the history of Parkinson's disease, and then discuss with you the causes of Parkinson's disease. So I think understanding the different causes, and there are more than one, of Parkinson's disease provides us with the most valuable information by which to design a form of treatment that will prevent the progression of the disease and possibly even cure it. I will then spend time talking about what treatments we currently have available for the disease. And some of those who have Parkinson's disease or are relative with Parkinson's disease will recognize some of these drugs. And I'll give you a glimpse into the future of some of the drugs that are being developed and perhaps, if successful, around the corner. So let me begin, of course, with the history of Parkinson's disease, which is actually a relatively young disorder, in the sense that there's a description by John Hunter of patients who had severe tremor, which might have been Parkinson's disease, but we know that there are many different types of neurological problem with tremor that may be quite different from that. The definitive description of Parkinson's disease as an entity came in 1817 with a publication by James Parkinson of the shaking palsy. James Parkinson was a very interesting character. He was, in modern terms, a family practitioner, and he worked and lived in Hoxteth, just to the east of here. And he was very socially aware, very politically active, and part of his time was spent treating patients. Another part of his time was spent handing out leaflets, which the government at the time thought were rather seditious, and he did spend some time in prison because of his apparently socialist views. But whilst he was out and about and practicing, he observed in the streets of East London individuals that he described with the shaking palsy. Now, it's of interest also that he never actually examined any of these individuals himself. He simply observed them day to day, and there were only 6 of them. And yet, despite that small number, and never actually laying his hands on these individuals, his description in the shaking palsy is a perfect example of the detail by which this disease can be documented. And in fact, it's very difficult to think of a modern text which is better in terms of clinical description than James Parkinson's shaking palsy. Now, he was, as you might have already gathered, quite a humble gentleman, and he didn't call the disease Parkinson's disease. He called it simply the shaking palsy. And it was about 15, 20 years later that the professor of neurology in Paris, Charcot, gave the name Parkinson's disease to this disorder. And of course, that's where we are today. So it'll be almost 200 years from when James Parkinson first described this disorder. And what I'm going to do in the next 15, 20 minutes is bring you up to date on what has happened in those last 200 years almost, in terms of our understanding of the cause of Parkinson's disease and also where we are with its treatment. Let me begin with how common is the disease. Well, as a general perspective, this is the second most common neurodegenerative disorder after Alzheimer's disease. So it really is quite common. It's got a prevalence of 115 per 100,000, but that's only an approximation. That means if you take 100,000 people, you'll find 115 with Parkinson's disease. But it varies according to age. So there are about 1.3 per 100,000, so 1 in 100,000 individuals with Parkinson's disease under the age of 45. My youngest patient with Parkinson's disease was aged 18, they're now a little older. So it can present at a very early age. But certainly as people get older, the disease becomes much more common. And you'll see that in the next slide, which is quite a good graphic example of that. Overall, in the United Kingdom, the lifetime risk of an individual developing Parkinson's disease is estimated at 3 to 4%. And that's because the life expectancy of an individual in the UK is now well into the 9th decade. The population of Parkinson's disease sufferers in the world is expected to double by 2030. And this is particularly because of the increased life expectancy in emerging nations such as China and South America. So you can see that the governments of the world are particularly interested in finding a treatment, a cure for this disorder, as well as for Alzheimer's disease, about which, of course, we've heard a lot over the past couple of days. But just to emphasize the issue about the most important risk for Parkinson's disease being age, you can see this graph taken from a number of different studies, which shows quite clearly that as people get older, so the risk for Parkinson's disease increases dramatically. So whatever cause we have for Parkinson's disease, we have to incorporate the part that aging plays. Let me tell you a little bit about where in the brain Parkinson's disease particularly involves. So this is a picture of the side of the brain. And what we've done is taken out a window of the brain so you can see inside the brain. Now, the part of the brain that's most involved in Parkinson's disease is the substantia nigra, or this part here. In fact, it's really quite a small part. You can see it with the naked eye. But the importance of this part of the brain is that it is like an autopilot for movement. So it looks after all those movements which you don't really have to be bothered thinking about, like walking, like smooth action of your hands, even movement of your eyes. So this is an important autopilot. And this autopilot projects its nerve cells to all different parts of the brain. So this is the part of the brain that's most concerned in Parkinson's disease. And if we take that part of the brain and we look at it under the microscope, this is what you'll see. So you'll see here on the normal side a part of the brain called the midbrain, which contains this substantia nigra, and it's called substantia nigra, which is Latin for black substance. And as you can see in that picture that I've just ringed, it is black, and it's black because of a substance called dopamine. Now, dopamine is a natural chemical in the brain which is used as a messenger from one nerve cell to another. So it's a very important part of the brain function. It's not the only messenger. There are lots of other different chemical messengers, but this is the one that's mainly used in the substantia nigra as part of the autopilot. And this dopamine is black when it's metabolized, so it turns its part of the brain black. But what you see in a patient with Parkinson's disease is that that black substance has disappeared. So the dopamine has gone. And if you look at that area of the brain under a microscope, you'll see some surviving brain cells like these, and inside them you'll see what we call Lewy bodies. That's that brown blob there. Now, Lewy bodies were first described by Lewy, or Lewy, in the early 1900s. But their significance to Parkinson's disease, in terms of the cause of Parkinson's disease, really only came probably about 20 years ago. We've always known that Lewy bodies are important as a marker down the microscope of Parkinson's disease, but only recently have we really understood the importance of the Lewy body to the cause of the disease. So that's the pathology of Parkinson's disease, if you like. That's what you see down a microscope. Now, when Parkinson's disease first begins, well, when does it first begin? You'll see that there are some genetic causes of Parkinson's disease, so you could argue that in those with the gene for Parkinson's disease, it begins in early development. But in most people without the particular genes for Parkinson's disease that I'll show you, Parkinson's disease probably develops some 10, 15 years before the diagnosis. And it begins very subtly. And it begins in the earliest phases, probably with a problem of this area of the brain. Now, this area of the brain actually projects into the nose and works smell. And loss of sense of smell is one of the earliest features of Parkinson's disease. And almost every patient with Parkinson's disease ultimately will develop some problem with their sense of smell. Now, loss of sense of smell is not specific for Parkinson's disease. It can just occur naturally. So it doesn't always mean that just because you can't smell the roses or the coffee that you're going to get Parkinson's disease. But it is nevertheless an early feature that we can now detect. And there are some other interesting early aspects. A dream disorder whereby patients shout out in their sleep or lash out can precede Parkinson's disease by several years. Now, those Lewy bodies that I described to you, those blobs contain something called alpha-synuclein. Now, alpha-synuclein is a protein, very common protein in the brain, and it accumulates in the Parkinson brain. And the accumulation of that protein, and the accumulation, therefore, of Lewy bodies, spreads through the brain. So it begins in that nose area and also in the bottom part of the brain, and gradually spreads up the brain and then around the whole brain. So this is a progression of the spread of those Lewy bodies from the very earliest stages to the later stages of the disease. And this spread of Lewy bodies is associated also with the loss of dopamine. Remember, that's the chemical messenger that I mentioned. And we can now see that loss of dopamine in the living patient. Before, we had to wait until, unfortunately, they died and we were able to look at the brain with a microscope. But now, with modern imaging techniques, you can actually see the loss of dopamine in living people. And this is a patient with Parkinson's disease who's recently been diagnosed. And what you see there is a sort of fire blobs which represent the intensity of dopamine in the brain. And you'll see that on one side in particular, this one here, there's less brightness, if you like. That means less dopamine. Now, that's the other interesting feature of Parkinson's disease. It starts on one side of the body. Why that is, we've got no idea. It's got nothing to do with it, whether you're left or right-handed. It starts on one side of the body. And you can see that on these imaging scans. As the disease progresses, so gradually that dopamine level declines. And you can follow this with sequential imaging by this technique. So we now have a very powerful means by which to see dopamine in the living patient. Let me now turn more specifically to talk about the cause of Parkinson's disease, or causes of Parkinson's disease. And I'm going to divide this part into talking about the environmental causes and also the genetic causes of Parkinson's disease. So before I show you the environmental causes of Parkinson's disease, I'd like a show of hands for those who think there are environmental causes of Parkinson's disease. Very good, very good. Okay, good, good. Well, I'm now going to show you the list of causes from the environment of Parkinson's disease. There aren't any. So we do not know of any causes of Parkinson's disease in the environment. Now, what we do know is that things that people do and some environmental factors can influence the risk for Parkinson's disease, but not actually cause it. So, for instance, exposure to pesticides, herbicides, rural living, and farming do increase the risk for Parkinson's disease, but only very slightly. You have to look at hundreds, thousands of individuals in order to get an idea that this is an influencing factor. So the risk factor of these is very small, otherwise we'd all see our farmers with Parkinson's disease, and that's obviously not true. Solvent exposure, doctors are said to have a 10 times increased risk for Parkinson's disease in some studies. And primary school teachers, an 8 times increased risk for Parkinson's disease. Red hair. And of course here I'm talking about your natural, not your post-hairdresser color. But red hair is associated with, again, a slightly increased risk for Parkinson's disease. Low vitamin D, another. So all of these factors here increase your risk. But all these factors here decrease your risk. So smoking cigarettes, and believe me, the more you smoke, the less your risk. Now, we don't know why smoking cigarettes reduces your risk of Parkinson's disease. And it's not because you die of a heart attack or lung cancer before you have the chance to get disease. There's something about smoking. And we don't know even whether it's the personality type that turns to smoking. It could be, although the evidence for that's not absolutely certain. Drinking coffee. 2 double espressos a day, particularly from Starbucks, I understand, so it's my plug. And I forgot to thank Starbucks for supporting this evening's. But 2 espressos a day also reduces your risk of Parkinson's disease. So when we've all been to the piazzas in Rome and seen the men out smoking and drinking their morning coffees, we know they're one step ahead of us on the neuroprotection. Non-steroidal anti-inflammatory drugs like Nurofen and so on, those slightly reduce your risk. Blood pressure tablet called isradipine. Black hair like mine reduces your risk of Parkinson's disease, and a chemical in the body called urate. So here we have some environmental influences rather than causes. So let me turn to the next. Genetic causes of Parkinson's. Who thinks there are genetic causes of Parkinson's disease? Good. Okay, that's very good. Those that didn't raise their hands have obviously not been listening, because you've already got the answer. And the answer is there are numerous causes, numerous different genetic causes of Parkinson's disease. The first one was described in 1997. And in fact, when President Clinton was the President of the United States at that time, they rushed through the final work on the description of the gene so that he could announce in the State of the Union message that the cause of Parkinson's disease had been discovered only the week before. Of course, politicians like to exaggerate a little, and indeed, although the cause of that particular gene defect was confirmed, it accounts for only a very, very small number of patients. But since that time, so over the last 15, 16 years, numerous other genetic causes of Parkinson's disease have now been described, and this is a list of some of them. In fact, we estimate that even with our current knowledge, we can probably account for about half of Parkinson's disease by genetics. Now, this does not imply that we're dealing here with single genes that pass through families. No, these are very complex genetic causes that aren't always necessarily inherited and don't always appear in other family members. So although we may identify a genetic abnormality in a patient, it doesn't immediately mean that that patient's children will be affected. In fact, quite the contrary, it's much less likely. Just to touch on one of the most recent developments in this area, at the bottom there, the so-called glucocerebrosidase risk for Parkinson's disease. This is the most important risk factor for Parkinson's disease, a mutation of this particular gene. And this was discovered only about 3 or 4 years ago. So work is accelerating at a pace in this particular area. Now, I've talked about the environment and the genetics, but of course, they're often linked. Perhaps not in this simple way of the environment or genetics causing the disease, but probably in this way of the environment influencing the genes in any one individual. And we now know this is a very important process. What we eat, what we do, can influence our own genetic makeup. It's not all inherited, and it's not all entirely stable and fixed. So it can be influenced. And this is probably, this very system here, is probably how a lot of cancers form. It's the environmental influence on the genes that control cell function. Now, in the next slide, I'll give a list of things that we know about in terms of biochemical abnormalities in the brain of the Parkinson patient that contribute to Parkinson's disease and the damage and death of those brain cells that contain dopamine. So this list is not exhaustive. It contains a number of biochemical abnormalities supported by the genetic causes of Parkinson's disease that have provided us with very important and very exciting glimpses into the potential pathways that cause the disease and which we can target for new drug therapies. In terms of thinking about the disease and potential therapies for the future, in the Parkinson brain at any one time, we think that there are brain cells that are only just beginning to malfunction. So they have what we call a molecular prodrome. So they're working perfectly well, but there's something not quite right. And then they become more damaged, but they're still able to function. And then as the disease progresses, well, they malfunction, then the disease appears or progresses. And finally, of course, there's degeneration, at which point these cells are dying. So this is a process through which the nerve cells are passing over several decades. And we're, of course, interested in that because it means that if we can intervene at this point and stop them malfunctioning, we will prevent the progression of the disease. And there are 3 areas of scientific research now focused on Parkinson's disease, which are doing exactly that. So these are 3 areas of mitochondria. These are like the powerhouse or battery of the cell. We know that the battery or energy producer of the cell in Parkinson's disease malfunctions. We know that the alpha-synuclein I've mentioned in Lewy bodies is important, how it sticks together, and interestingly, just over the past 2 or 3 years, how it can propagate. If you think back to that picture I showed you of how the red of the Lewy bodies and alpha-synuclein spreads throughout the brain, that gave people a clue that maybe there's something important about that spread. Now we know from another disease, prion disease, that proteins can spread from one cell to another. And there was a clue that this might be happening in Parkinson's disease just a few years ago. You may remember about 15 years or so ago, studies were done in which nerve cells from human embryos were taken and implanted into Parkinson's disease sufferers. Now, these embryo implants improved the symptoms of Parkinson's disease in some patients. Now, those patients, of course, some of them have now died, and we've been able to look at the brains of those patients who had these fetal implants. And these fetal implants now really are 13, 14 years old in terms of the age of the cells. And when we looked at the nerve cells of the host, that means the patient, of course we saw the characteristic brown blobs that I showed you before in the nerve cells. But what was so extraordinary and startling was that in the cells of the graft from the fetus, you saw the same problem. So these nerve cells, only 13, 14 years old, had developed the same problem that it had taken the patient 60, 70 years to develop. Now, there are many ideas about how this came to pass, but the most important one was that the alpha-synuclein abnormal protein was spreading from the patient to the new fetal cells. And this idea of spread has now been confirmed in numerous different models. So we now know that underlying that spread of involvement is actually spread of protein being passed from one nerve cell to another. And there are ideas, in fact, that the earliest nerve cells to be affected are those in the bowel, and that the abnormal protein may spread from the bowel up the nerves, through the spinal cord, and into the brain. This has given us some ideas about, of course, part of the cause, but importantly, part of the potential treatment for Parkinson's disease. Now, the last bit of the hot area is the so-called lysosomes. These are the garbage collectors, the rubbish collectors of the cell, and they don't work properly, which is probably why the alpha-synuclein collects into those Lewy bodies that we see. So this is another important area of research. Now, I'm going to turn from the research into the cause and the mechanism to now briefly the clinical features of Parkinson's disease so that we can turn to the treatment. So the clinical features of Parkinson's disease, well, there are 3 very common features and then a number of other features that a patient may or may not have. 3 common features are the rest tremor. The patients may notice that one hand or perhaps one foot may begin to tremble, particularly if they're nervous. They notice some stiffness and rigidity. They don't do things as quickly. Their partner complains of them slowing down. Their gait, walking, may be slower, and they may lose their erect posture. And their bradykinesia is another example of that. Bradykinesia is another word for slowing. So these are the common features of Parkinson's disease. And here you see the so-called non-motor features, which are the numerous other symptoms that can develop, not in every patient, but in some. And you'll see those that I put in orange are those that can develop even before the tremor, the stiffness, and the slowness. The loss of sense of smell, the sleep behavior disorder, depression sometimes, and constipation. Let me now turn from that to the treatment. Now, the treatment which I'm going to briefly review is what we call symptomatic treatment. That is, we can improve the symptoms that I've just shown you, but we're not changing the course of the disease. We're not necessarily slowing it down. The treatment of the symptoms of Parkinson's disease revolve around the replacement of the chemical messenger dopamine. Remember, this was the chemical messenger in the nerve cells of the substantia nigra that is lost. This is the chemical that works the autopilot. So the different strategies which have developed for the treatment of Parkinson's all focus on replacement of dopamine. Now, the oldest drug, yet still the most effective, levodopa, was first given about 50 years ago, still remains the mainstay of treatment. And levodopa is a tablet you take by mouth, and it's converted in the brain to dopamine. And it's then released to react with the next nerve cell. The next drugs that became available were the so-called dopamine agonists. These are synthetic dopamine. So what these do is interact directly with the dopamine receptors, so substituting for the brain's own dopamine. So like a synthetic oil or dopamine. And then there are the monoamine oxidase B inhibitors. Now what these do is inhibit the breakdown of dopamine. So that means that the dopamine lasts longer and is able to function passing messages from one nerve cell to the next longer. Anticholinergics, again, have been used for many years. They work by modulating, changing the level of dopamine very subtly. So they're quite good drugs, but they do have side effects, similar to amantadine. So anticholinergics and amantadine are used for specific circumstances in Parkinson's disease. So here's a range of drugs, and even within each of these classes of drug, there are many different examples. Tablets, patches, injections, all of these are available as treatment. So there's lots of drugs, so how do you decide which to give a patient? Which one is best for any given patient? And the answer to that is each patient is different, and you have to take into account the patient's age, what other illnesses they might have, what do they do, are they still working? Do they need their hands to work effectively? How severe are their symptoms? Mild, moderate? What's the likely side effect or adverse event profile? What does the patient want? Very importantly. Often patients are very well informed, and they may have an idea about what they would like and when they would like it. And finally, in some areas of the world, economic circumstances. Can the patient afford to pay for different types of treatment? Fortunately, in this country, that is not a determinant of treatment. So, different drugs for different patients at different times. And this and the next two slides summarizes the progress or pathway that a patient may follow. First of all, to decide whether to treat or not. And when the patient wants treatment, and when the doctor recommends the treatment, determine what is best for which individual patient. And there are three choices for the first drug for Parkinson's disease generally. The monoamine oxidase B inhibitor type, like selegiline or rasagiline. The dopamine agonist type, like pramipexole, ropinirole, reticotine patch. Or levodopa itself, Sinemet, Madapar, Stalevo, etc. As time goes by, the patient may need more medication. Now, the tendency is either to increase the dose of the drug the patient is taking, if that's possible, or to add another drug to that. Inevitably, what happens is that patients end up on a combination of therapy. Often all three, monoamine oxidase, dopamine agonist, levodopa. And that occurs and develops over time. The sequence in which we give those, the dosing at which we change, all determined by the patient's own characteristics. As time goes by, sometimes complications of Parkinson's disease develop. The drugs don't last as long as they used to. Patients start to get additional symptoms of involuntary movements. And that's when we begin to think about other forms of treatment, such as injections or even surgery. And this is, I think, a very interesting part of the future of Parkinson's disease treatment. Not in the sense that it's a future treatment, but perhaps how frequently it's used. Deep brain stimulation. This is a form of surgery first developed probably about 15 years ago, although the idea came from surgery that was done in the 1950s. But deep brain stimulation we've had for about 15 years. It involves the insertion of a wire through the brain into a particular part of the brain to stimulate that part of the brain. And usually the wires are inserted on both sides of the brain. Now this, of course, sounds terrible to anybody who's sitting there thinking, well, gosh, it's the last thing I would want to have two wires inserted into my brain. The complication rate is extremely low, less than 1%. So it's a relatively safe. No one's going to say for a moment that this is something that can be done without very careful consideration. This is something that's carefully considered, but properly done. The complication rate is very low, and the benefit is very good. And recently, there have been studies where deep brain stimulation has been tried on patients earlier in the course of their Parkinson's disease, rather than later in the disease, with good effect. There are other forms, non-medical, non-tablet forms of Parkinson's disease. I mentioned fetal implants, the research on growth factors injection, and cell therapies or stem cell therapy. These are not yet available. I don't think they'll be available in the next 5-10 years, but there's something certainly that research is looking at. So if we now come to the end of the story of Parkinson's disease, we can begin to think, what are the so-called unmet needs of Parkinson's disease? We've done very well with Parkinson's disease. We understand a lot more about the causes of Parkinson's disease just really in the last 15 years. We know quite well how to treat the symptoms of Parkinson's disease, but not all of them. So we can't always control some of the side effects of the medication. We can't control all of those features that are not due to lack of dopamine. And most importantly, we can't slow the disease down or stop it yet. That's the most important unmet need, certainly. But I think that we've got some good ideas, and we've had them for a while, and people have been working on these interventions to prevent the progression of those biochemical abnormalities I talked to you about. Problems with the mitochondria, the lysosome, the protein aggregation, and maybe even to restore function to damaged cells. So, in terms of thinking ahead for the next 5 years, there are plenty of options, precisely looking at those processes to slow down the progression of the disease. And here are some of those targeted to those parts of Parkinson's disease as they evolve from the earliest phase onto the later stages of the disease. So plenty of research, plenty of options, and I think plenty of room for optimism in working towards a drug that will truly slow down and perhaps even prevent the progression of Parkinson's disease. So in terms of the drugs available, the drugs in the clinic, the drugs in research, there are many of them. Looking at the symptomatic treatment of Parkinson's disease, looking at the potential slowing the progression of Parkinson's disease. So, as I say, a lot of work, a lot of research, and I think a lot of room for optimism. So, on that particular note, I'd like to end. I would like to actually truly give a particular plug to Parkinson's UK. Parkinson's UK is the patient organisation for Parkinson's disease. It has been a very generous supporter of much of the research that I've shown you tonight, particularly in the United Kingdom. It plays a very important role in supporting research, but also in providing information to patients and their carers, and also to help supporting care for those individuals. So I think Parkinson's UK nationwide does a wonderful job, and the Central London Parkinson UK branch are represented here. There we are at the back. But if anyone has any questions about that in particular, please feel free to ask at the end, but also otherwise to look to the internet and look up Parkinson's UK. So thank you very much for your attention.